Thank you so much for the planning committee to invite me here today. It gives me great pleasure to talk to you about tailoring neoadjuvant therapy for gastroesophageal cancers. I strike the word neoadjuvant and wrote perioperative, so we'll kind of get into the talk and see whether that would be appropriate or not. So let's kind of revise what we know so far. I'm speaking probably to a majority of the audience in surgery, so this should not be brand new news, but globally, the burden of gastroesophageal cancers accounts for more than 1 million of cancer cases diagnosed annually. It's more prevalent in males than females. When we look at the upper GI tract, all the way from cervical esophagus to the stomach, you can see two different histologies. Your upper part of the esophagus and middle third of the esophagus are primarily squamous cell carcinoma, and spanning from the lower third of the esophagus all the way to the stomach are primarily adenocarcinomas. What's important to consider is your GE junction, because that's where most of the controversy lies. GE junction cancers are again subclassified into 3 different classes based on the CWID classification. You had class 1, where your tumor epicenter is 1 to 5 centimeter proximal to the anatomical cardia. And that is typically treated like esophageal cancer in most clinical trials. When we look at CWID 2, that's the tumor epicenter 1 centimeter proximal to the anatomical cardia or 2 centimeter distal to the anatomical cardia. Spanning in that space, that's CWID 2. Again, primarily clubbed with esophageal cancer in clinical trials. When it comes to class 3, those are where the tumor epicenters are 2 to 5 centimeters distal to the anatomical cardia, and they are primarily clubbed with gastric cancers for clinical trials. When we talk about, as a medical oncologist, I primarily see stage 4 cancer patients in my clinic, but again, my surgical colleagues will see locally advanced patients, and those are defined as anyone that's T2 or higher or node-positive disease without any evidence of M1 disease. These locally advanced cancer patients are indeed candidates for surgery, barring any medical comorbidities or patient preference. So let's talk primarily about these locally advanced cancer patients. There are always 2 schools of thought. One, where people prefer neoadjuvant chemoradiation, or 2, people prefer perioperative chemotherapy. Their institutional preferences, surgeons' preferences, whether you have good radiation oncology per people on staff or not, so that kind of varies. When we talk about progress that we've made over the past several years, we always say, oh, we really haven't made that much progress. But if you look at the timeline, okay, all right, maybe the changing the bulb is not the right time right now, but when we look at the timeline of the clinical trials that have been performed over the past several years, there have been multiple of them, and they have given us mounting information to keep doing better and better. Some of these are highlighted or bolded, and those are some practice-changing trials, but we'll kind of go a little bit in detail about all of these. So yes, locally advanced cancers, surgery is preferred, but the first question that came out was, can we do chemo prior to surgery and offer better survival? So is chemotherapy with surgery better than surgery alone? So I picked out these 3 trials. OEO2 was a mixed bag of cases, mixed bag meaning you have squamous cell cancers as well as adenocarcinomas. And these were treated with 5-FU cisplatin for 2 cycles prior to surgery versus surgery alone. And the main takeaway was, yes, R0 resection rate, which was achieved mostly because of the preoperative chemotherapy, did improve survival, but this included both squamous and adenocarcinoma patients. Next comes the MAGIC trial. That was a practice-changing trial at that point in time. This was an epirubicin-based triplet regimen where it was given in a perioperative fashion. Chemotherapy 3 cycles before surgery, surgery, and then 3 cycles post-surgery in a sandwich fashion. This primarily included gastric cancer patients, so 3/4 of the patients were gastric cancer. This led to a significant improvement in overall survival. I would like you to kind of just keep a note of the median overall survival achieved with chemotherapy. That is 26 months, because we kind of use that yardstick moving forward. So this trial established that perioperative chemotherapy was indeed the standard for locally advanced gastric cancer patients. One of the challenges was completion of all treatment. Only 42% patients were able to complete all assigned treatment. Next one is the FFCD 9703. It's by the French group. And this included, again, cis-5FU, total of 6 cycles given perioperatively. This included more of the esophageal adenocarcinomas and G junctions, but only a quarter of gastric cancer patients. So it's a little bit of a flip. But again, that also showed an improvement in overall survival, a small patient population though. So again, this showed that perioperative chemotherapy was better than surgery alone. Similar challenges as with MAGIC in completing all treatment, but as I mentioned, 75% of these were esophageal or G junction tumors. Then the next question came, what if we added more treatment to the chemo? So OE05 was where a doublet chemo was compared to a triplet chemo alongside surgery, before surgery. This included primarily esophageal adenocarcinoma G junction tumors, and there was unfortunately no survival benefit. The second trial is STO3, where there was addition of bevacizumab to epirubicin-based treatment. That's a targeted drug, a vascular endothelial growth factor receptor antagonist. And that also did not show any improvement in overall survival. So again, neither a doublet chemo or addition of a targeted treatment to existing chemotherapy backbone was able to extend survival. Now is the second school of thought about chemoradiation. Again, in that you had two different sides of the world. One, in the European side, people preferred neoadjuvant chemoradiation, while as in the US, which is the Intergroup 116 trial, it was planned as a post-operative chemoradiation. So Intergroup 116, surgery followed by chemoradiation with a 5FU leucovorin backbone. This was primarily gastric cancer patients. 80% of these were gastric cancer. I do not need to tell a group of surgeons about D2 lymphadenectomy, but at that point in time, D2 lymphadenectomy was not common. Only 10% of these patients had D2 lymphadenectomy. Then was the CROSS trial, where neoadjuvant carboplatin paclitaxel with radiation was offered, and that included both esophageal squamous cell as well as esophageal adenocarcinoma, no gastric cancer patients. And I put in the overall survival for adenocarcinoma patients only, but there was an improvement in overall survival. Now, if you look at the median overall survival for the CRT group, which is chemoradiation group, you're now seeing a 43.2 months of median overall survival. So we learned in MAGIC, the median overall survival was 26 months, with neoadjuvant chemoradiation, 43.2 months. So we're going to try to keep building on this data to try and see how, in the next coming years, we're able to improve the care for our patients. So Intergroup showed that post-operative CRT offers benefit in gastric cancer patients, but of note, majority of those patients had received less than D2 lymphadenectomy. They did do a subgroup analysis of patients who had D2 lymphadenectomy to see if there was any advantage of adding CRT, but it's a very small subgroup of patients, which does not really delineate whether the benefit was real or not. 54 patients had grade 3 or 4 hematologic toxicity, so it's not an easy regimen to tolerate, especially after surgery. CROSS was another landmark trial which showed that preoperative chemoradiation improved survival in esophageal cancer patients, both squamous as well as adeno. Now people say, okay, why don't we merge both together, give patients chemo as well as chemoradiation? So then can we learn about the role of induction chemo followed by chemoradiation? POET was the first study which showed 5FU cisplatin followed by surgery versus 5FU cisplatin followed by chemoradiation followed by surgery. And you can see that unfortunately did not improve overall survival. So addition of more chemo prior to chemoradiation did not translate into a survival benefit. There was a high rate of in-hospital 30-day mortality, about 11% in patients that received chemoradiation. Then comes the critics trial, where patients received the perioperative chemotherapy in the control arm, but in the experimental arm, the post-operative chemo was replaced with chemoradiation. All right. This included majority of gastric cancer patients, 83%. Unfortunately, that also did not translate into a survival benefit. Next comes the CLGB 80803. This is the most recent trial published in 2021. This is not quite so much whether induction chemo followed by chemoradiation versus perioperative chemo is better. This was basically designed to see if PET-directed therapy can be used in order to guide treatment. So patients were started either with induction FOLFOX or induction carboplatin paclitaxel. After a couple of cycles, a PET-CT was performed, and if there was a PET response, which is defined as a decrease in SUV by 35% or more from the baseline, then they were considered as responders. If you're a responder, then you continue with the same chemotherapy backbone with radiation. If you're a non-responder, you switch to the different chemotherapy backbone with radiation. And this again included mostly esophageal adenocarcinoma patients along with some GE junction cancer patients. When you look at the far right corner of the median overall survival estimates, overall just doing the analysis for the subgroups, there was no significant survival benefit. Even if you compared responders versus non-responders, there wasn't any significant survival benefit. Okay, am I doing something?
No, it's not you at all.
Thank you. So this showed that neither choice of chemotherapy or using PET to guide response led to a statistically significant survival benefit in esophageal adenocarcinoma patients. So again, I'm sorry that we went through a lot of trials in a short period of time, but how do we balance all this information? The key takeaways when we started at the beginning of this decade was what favored neoadjuvant chemoradiation. That was the cross trial in esophageal cancer. What favored perioperative chemotherapy? That was the FFCD in esophageal cancer, and MAGIC and FLOT in gastric cancer. We're going to talk about FLOT in just a minute. The major challenge with perioperative chemotherapy was completing all assigned treatment, that is all perioperative treatments. So let's talk about FLOT. So what showed that epirubicin was no longer magical? So FLOT trial included mostly adenocarcinoma patients, GE junction and gastric. There were 76% of these patients that were classified as gastric cancers or GE junction CEVA 2 or 3. So the MAGIC regimen was compared to FLOT, which includes another triplet, 5-fluorouracil, docetaxel, oxaliplatin. The only difference being it's given every 2 weeks, 4 cycles prior to surgery, 4 cycles after surgery. 80% of these patients were node positive. Looking at the survival curves, the OS is shown on the left side. You see a median overall survival of 50 months. So we went from 26 months, that was historical in MAGIC, to 43.2 months, that was in CROSS, to now 50 months with FLOT. You'll also see that the MAGIC arm did much better than in the original MAGIC study, which is at 35 months. It's said that as years have gone by, we've learned to take better care of our patients. We've done better surgeries, so that accounts for that. PCR rates, pathologic complete response rates, were higher with FLOT as compared to the MAGIC. MAGIC was 6%, FLOT was 16%. Again, there was a high degree of patients with hematologic toxicity, diarrhea associated with FLOT. So after this came out, epirubicin went out of fashion. Epirubicin was no longer used. Next is the Top Gear study. So what happens when we add CRT, or chemoradiation, to perioperative chemotherapy? Again, resectable gastric G-junction cancer patients. You'll have your control arm, which is at the bottom, 288 patients assigned to ECF-ECX primarily, but then when the FLOT study was read out or was presented, there was a fraction of patients that were treated with FLOT. That is, I believe, a third of the patients were treated with FLOT. And in the experimental arm, you had perioperative chemotherapy, but you had also preoperative chemoradiation. So after doing the pre-op chemo, you had chemoradiation with 5-FU followed by surgery and then more chemo. Again, doubling of PCR, sorry, I went a little fast. You can see here the R0 resection rates were slightly better in the CRT arm. PCR rates were definitely better in the CRT arm as compared to chemo. However, did not translate into an improvement in overall survival. So more treatment, adding or switching radiation with chemotherapy was not helpful in improving survival. Again, in terms of completion of treatment, only 48% in the CRT arm and 59% in the perioperative chemotherapy arm were able to complete all perioperative treatment. So FLOT and the Top Gear studies have shown that perioperative chemotherapy should be considered as the standard for locally advanced gastric and G-junction CEVER-2-3 cancers, and there is no role for chemoradiation. Now, let's talk about esophageal cancer. Can we optimize perioperative chemotherapy for esophageal cancer patients? So the first study we'll talk about will be the Neoadjuvant study. Again, this was presented about 2 years ago. Adenocarcinoma, esophageal cancer patients were randomized to receiving perioperative chemotherapy versus cross. Again, when the study was first designed, epirubicin-based triplet was the standard. Then later, it was amended to include patients treated with FLOT as well. So 15% patients received FLOT in the perioperative chemotherapy group. The radiation dose was 41.4 gray, which was the standard in the cross study. But as we all know, the standard has now changed. Many institutions now use up to 50.4 gray of radiation. Again, only 41% patients completed treatment in the perioperative chemotherapy arm. You will see that percentage very similar across all studies of perioperative studies, 42, 46, 41. Again, unfortunately, there was no survival difference when you compared perioperative chemo versus cross. PCR rates were definitely better in the chemoradiation group. R0 resections were better. Unfortunately, there were more grade 3, 4 neutropenia toxicity with the perioperative chemotherapy group. Next, I want to talk about the ESOPEX study, which for most of us has been practice changing, depending on how soon we adopt a new practice. This is a newer study randomizing patients to receiving FLOT. So again, very pure. There's no mix-up of epirubicin-based treatment. All patients in the perioperative group received FLOT. The other group received the cross regimen. Again, 41.4 gray considered to be the standard. I'll briefly touch upon some of the new trials that have come out in the trimodality setting, which is Checkmate 577. Again, at that point in time when the study was designed, 577 was not read out. So this study showed that there was an improvement in overall survival when we looked at the FLOT group over the cross group. If you look at the median overall survival, just pay attention to the far left corner, median overall survival in the FLOT group is 66 months. Much higher, did much better than what the original FLOT study did, which was 50 months. Cross, on the other hand, 37 months, did much worse than what it did in the original study, which was 43.2 months. So again, we still have to wait for the final publication and long-term follow-up data, but that's the data so far. If you look at the clear subgroups that derive benefit, younger patients, those are less than 60 years of age. T3, T4 tumors, node-positive tumors. Those are clear subgroups of patients that derive benefit from perioperative chemotherapy. Again, 52.5% patients were able to complete all assigned FLOT treatment. When you look at PCR rates, 16.8% versus 10%. 16.8 was similar to what it did in the original FLOT study. But if you look at the PCR rates for the cross, it's 10%. In the original cross study, it was 24% for the adenocarcinoma group. So it did much worse somehow here. If you just superimpose what I originally said about the original papers of Flott and Cross, this is how I've superimposed their overall survival and 3-year and 5-year overall survival rate. Again, we're awaiting long-term follow-up data and final publication to see how it results. So now there is data from the ESOPEX study that perioperative chemotherapy offers survival benefit for esophageal adenocarcinoma patients as well. The next section I'm just going to briefly touch over because that's got some implications about how I'm going to do my takeaway points, but I think Dr. Yoon will go in more detail about these. So immunotherapy is not left far behind even in the locally advanced setting. As I mentioned, we'll talk a little bit about the Checkmate 577. This was a global randomized phase 3 study where patients with both esophageal adenocarcinoma and squamous cell would receive trimodality therapy, which means neoadjuvant chemoradiation followed by surgery, and had not achieved a pathologic complete response, but did receive R0 resection, were randomized to receiving nivolumab versus placebo, and that showed an improvement in disease-free survival. So 3/4 of the patients were adenocarcinomas. The PDL1 was measured by TPS, that is tumor positive score. We'll talk more about CPS because that's the language that GI oncologists understand. But I wanted to show you the disease-free survival curves, which showed that nivolumab indeed improved disease-free survival. Also, when we look at granularity with the histological subgroups of squamous cell and adenocarcinoma, there was survival benefit. PDL1 CPS score, so there were exploratory analysis to see how the CPS scoring played into the disease-free survival. So patients with a CPS of 5 or more had an incremental benefit with the addition of nivolumab in the adjuvant setting. So that was a takeaway that adjuvant nivolumab improved disease-free survival after trimodality therapy. Then there were some perioperative chemoimmunotherapy trials, Keynote 585 and Matterhorn. Keynote 585 has been completely read out. Matterhorn, we're awaiting event-free survival data. Very similar study design. Keynote, as the name suggests, pembrolizumab is the immunotherapy of choice with perioperative chemotherapy, the perioperative chemotherapy being doublet, not a triplet. But there was a small cohort of 200 patients that were treated with the triplet combination as well, which is the Flott with the pembrolizumab. And Matterhorn is durvalumab with Flott, so this was a more pure Flott study as a chemotherapy backbone. The inclusion criteria was slightly different. In Keynote 585, T3 or higher, Matterhorn T2 or higher were allowed. Primary endpoints, EFS is the primary endpoint for Matterhorn. Again, when we talk about completing perioperative chemotherapy, again, we see very similar rates, anywhere in the high 40s to 50s, where patients end up completing all treatment. With the Keynote 585 and Matterhorn, if you look at them side by side in terms of demographics, there are some subtle differences. Keynote 585 had more of the diffuse histology, which is almost 44%, and 22% in the Matterhorn study. When you also look at patients, sorry, I think that was it. Yeah, Asian patients. So Asian patients, again, were more common here in the Keynote 585 versus the Matterhorn. So Keynote 585, unfortunately, did not demonstrate an improvement in event-free survival. So the far right corner is a Kaplan-Meier curve for the main cohort, which is the doublet chemotherapy with pembrolizumab. Their p-value threshold was set at 0.0005, and the p-value that they obtained was 0.0, I can't see, I'm sorry. But since they did not achieve that threshold, it was not considered to be a positive study. Matterhorn did report superior PCR, that's pathologic complete response. You see a delta of almost 12 to 13%. If you look at the German subgroup, you see an improvement from 13 to 30%. The Germans are much more stricter about doing staging laparoscopies to rule out those occult metastatic disease patients, so that's why we see that much of a difference there. So the key takeaway is data from perioperative chemotherapy with durvalumab is awaited to see if that will change the treatment landscape for treatment of locally advanced gastric G-junction cancers. So these are my takeaway points. Perioperative chemotherapy with FLOT is a preferred standard regimen for locally advanced gastric G-junction cancers. When the results from Matterhorn do mature and are presented, depending on whether it's a positive study, that will change the standard to a perioperative chemoimmunotherapy. Based on the ESOPEC data, perioperative chemotherapy with FLOT is now also considered to be the new standard for treatment of locally advanced esophageal adenocarcinomas and G-junction Siewert-1 tumors. There are some gaps in the knowledge. Number one, locally advanced patients that are not candidates for surgery. So you have the Keynote 975 that it's been accrued, but data is still to mature, which is a definitive chemoradiation with immunotherapy trial. And if Matterhorn shows benefit in the gastric population, how will that translate to perioperative treatment in the esophageal adenocarcinoma patients? And whatever I just discussed does not apply to MSI-high tumors. Dr. Yoon will go in much detail about that one. And I think we'll take questions at the end during quick Q&A session, but that's my email address and that's my X profile. Thank you.